everyone. We're going to start in just about a minute here, so hold tight. All right, it looks like everyone's just about coming on right now, so we'll go ahead and kick it off with some introductions. Thank you everyone for joining today's webinar. We have a really exciting guest today that's going to be presenting from the Healthcare Advisory Board, Rebecca Tyrell. So thank you to the Healthcare Advisory Board for helping us with this and presenting today. Rebecca's from the Research and Insights Division at the Healthcare Advisory Board, and she's a part of the Population Health and Advisor team, which leads research on care management and other population health topics, which equips leaders with practical support to achieve their transformation goals. So she'll be presenting alongside with our VP of Marketing at Enghouse Interactive, who is Scott Logan. He's been with us for a little over 3 years and in the telecom industry for about 5. So he'll be presenting along with Rebecca and adding some insight as she starts today's presentation. So with that, I will hand it over to Rebecca.
Great. Thank you, Nicole, for the introduction. As she said, I'm Rebecca Tyrell. I'm a research consultant with the Population Health Advisor team. And so in my day-to-day work, I'm on the phone with chief transformation officers, with VPs of population health, care managers, and a host of other leaders who are responsible for managing care transformation efforts. That's our hospital or health system. So through this role, I have the unique opportunity to really understand what those different leaders are experimenting with, what they're grappling with, what things that are working, not working. So we cover a wide range of population health topics. So really excited to be here today to present some of our research on improving patient engagement to really advance population health. So before we get started, I just wanted to move through a couple of quick housekeeping slides. So upon starting the GoTo webinar, your audio will automatically default to the mic and speaker option, and we recommend switching to the telephone option to provide a higher quality sound. So to do so, if you haven't already, just expand the audio tab that's located on your GoTo panel and select the telephone option. The required dial-in number and access code will appear below that on the screen. And should you have any questions, just feel free to submit them via the questions box on the bottom of your GoTo panel. So if you have a question, whether it's technical or otherwise, just type it into that question box and press send, and Nicole will be helping us moderate those questions throughout the presentation. In addition, you can click on the blue and white square icon on the left side of your GoTo panel to maximize the presentation area. So the orange and white arrow will allow you to minimize or maximize the GoTo panel. And then last thing I will mention is that we will provide a PDF version of today's web conference slides with actually a few additional case studies and pieces of information that we probably won't go through during the session today, but that I think will be really interesting and helpful as you review the material after today's session.
All right, so before we get going, this is Scott. We want to take a quick poll. Are you currently trying to improve patient care or service through the contact center? Looks like the poll, there we go. Whoops. Do you want to restart the poll there? Looks like we jumped the gun on that. Sorry for the technical difficulties here. But what we want to do is just take a quick peek at seeing this is a healthcare and a contact center and patient services combined topic. So just a lot of these initiatives cross over. We're trying to make the connection between, or not trying, showing the connection between how the contact center, which may only be used for 1 or 2 functions, can actually benefit more parts of your healthcare environment than what you normally anticipate, and wondering who's currently going down that path now or not. So if it looks like if we can't get the poll going again, maybe you could just shoot into a chat a yes if you have something in place, yes but no current initiative, or no just researching real quick, and we can take a look at those in the chat box or Q&A box, and we'll relay the results of that back at the end of the webinar. But basically just trying to see if we're hitting the mark here, and hopefully this will actually change your mind a little bit about the different things you could do that could impact your business or healthcare provider system immediately. So we can go ahead and close the poll out and continue on with the presentation.
Great, thank you. And sorry for the technical difficulties there. But in terms of an agenda for the next 45 minutes or so, there are just really 4 key things we want to make sure that we touch on. So the first is just the industry shift and commitment to population health that's happening. The second is the role that care transformation in particular plays in the shift, so really how providers are thinking about it and what problems it's intended to solve. And then really doing a deep dive on the contact center functionality piece. So what are the next generation population health functions that we're seeing increasingly being used, and how do we tie that back to the goals of care management, the needs and pain points of providers, and the care and access needs and demands of modern consumers. And then at the end, we'll land on 2 key slides that I'd recommend printing out and keeping for reference. They just recap some of the key takeaways that I want to reinforce, and then we will, of course, open up the floor to questions. So to kick us off, I'll just say that as far as we can tell from the advisory board perspective, population health and the shift toward value-based payment models is a development that's not going to go away. So it's something that we all need to continue investing in. CMS has even signaled their commitment to having more and more payments tied to value-based care or high-quality outcomes over the next couple years. Given that they're our biggest payer, this is a really important signal and one that we've commented a lot on. But what this actually means for providers, and particularly for population health managers, in terms of what they need to do, are the 3 things that you see outlined here on the slide. And so you've often probably heard these referred to as the triple aim of healthcare. So we're really looking to improve the patient experience of care, improve the health of populations, and all while reducing per capita total cost of care. So these are the goals that really undergird everything that health systems are investing in. And to achieve these aims, particularly the first 2 that I just mentioned, some of the key shifts that we're seeing are emphasizing access and patient-centeredness. So key topics when we're talking about contact centers in particular. So we're moving farther and farther away from being okay with having long wait times or inconvenient scheduling processes, and really looking to expand access and honor patient preferences and interests. So every day we get questions like, what kinds of telehealth or virtual visit capabilities should I offer? Or how can I leverage my contact center to help streamline appointment booking? Or even, what's the best mechanism for providing reminders to patients about overdue screenings or upcoming visits, for instance? So all topics where patient satisfaction and ease of use are really key, which ultimately helps drive in-network utilization, which of course means better control over cost and quality. So something that leaders and providers are acutely aware of. And what about that financial piece? So at the highest level, there's really 3 key levers we have for impacting avoidable cost, which is really essential to managing population health. So the first lever is plan management, or essentially how you're using your benefit design to manage utilization. The second is partner engagement, or how you're engaging providers in initiatives that standardize care or referral protocols, for instance. And the third is care management, where we're working directly with patients to improve self-management and engagement. And ultimately, while we need all 3 to succeed in managing population risk, I think the greatest near-term opportunities for health systems come from that comprehensive care management piece. This is also where providers have the most control, since it informs what you're actually doing when you're interacting with patients, and really is probably where I spend the majority of my time and have most of the questions coming in from providers and population health executives. But the big challenge of care management in particular is really identifying exactly what we want from our efforts. So across our research, we hear a wide range of definitions and get a lot of questions around the difference between care management, case management, care coordination, all these different buzzwords that you probably hear. So at one end of the spectrum, care management is described as that tail end of an acute care episode in the hospital, comprised of equal parts care coordination and utilization review, or essentially discharge planning, so a function we're all familiar with. But then at the same time, we've encountered numerous stories on the flip side of the spectrum. So patients who are getting home visits, they're having people install handrails in their house. Somebody is calling them every day to check in, see how their medication regimen is going, if they're experiencing any side effects. They might schedule taxi services for them to show up to a physician visit. So really comprehensive wraparound, sort of concierge type of support. And I'd say in comparing these two models, the first one isn't quite ambitious enough because it minimizes the role of education and coaching and prevention, while the second is too resource intensive to be feasible for most organizations given limited resources and an infrastructure that doesn't quite support this type of management right now. I think it's definitely an ideal, but given where we are and the resource constraints that we do have, what is it that we're ultimately looking for? So if we were building the care management enterprise from scratch, we could probably agree on an ideal set of features. So first, we want to make personalized care plans for patients. So as you can imagine, complex patients have really complex needs, and not all of them are clinical necessarily. So we need the flexibility and the time to really identify these needs, whether they involve nutrition, health literacy, mobility, or even all of the above, and really orienting the care plan towards goals that are meaningful to both the patient and also appropriate for our clinical and cost benchmarks as population managers. The ideal enterprise also functions effortlessly across the continuum to drive improvement via a unified care plan. But to do so, we need to move patients to the most appropriate ambulatory access points, really minimizing high-cost utilization. And finally, the care management enterprise operates according to a clear set of incentives. So goals should not only be transparent, but all the providers who are working with the patient should be accountable for achieving the same metrics. And as we're all aware, we're not starting this process from scratch. So, that was a perfect vision. And everyone who we talk to and who you interact with likely has some form of case management or care management in place today. But these existing resources aren't quite designed for population health. So they were created under a fee-for-service system, and as a result, they often tend to address only the specific needs of the individual care silos that they're housed in. So it often misses that complete picture of a patient's complex clinical and non-clinical care needs. We can't overcorrect for that problem, or will result in having an overextended, ineffective resource, because it's really a small percentage of patients who consume the majority of resources. So prioritization of effort is really a key theme of the day here. And the care management we're going to talk about today really refers to longitudinal care management in primary care, which we've prioritized for the highest risk patients. This is where health systems are investing a lot of dollars and staff time and where they're asking a lot of questions. So when we say care management, it's that process of working with a patient over a period of many months to help them manage their chronic conditions and get them up to date on their preventive care. So now that we can agree that population health is a long-term commitment that we're betting on, it involves being more patient-centric and going further upstream to prevent some of these acute events from happening in the first place, I want to deep dive on how organizations are thinking about care management investments and what decision points they're facing. And as I mentioned, care management is really where we spend the majority of our time talking to hospital and health system executives, because it's where providers have the most control and also where they're getting a lot of pressure from the payers. So this is important because it's where they're feeling understaffed and where contact centers can come in by really helping to extend the care team, relieving some of this pressure to be everything to everyone while hitting a lot of quality targets. So what you see here on the screen is something that we spend a lot of time talking through with executive teams, and one of the slides that I'd recommend printing out for reference. And really what it does is summarize some of the key decision points that providers face when they're refining their care model, deciding where to invest dollars, figuring out what might need improvement to generate some increased ROI. So just to orient you to what's on the slide here, there's really 3 key phases that we see providers going through. The first is just defining what their care management strategy is. So which patients do we need to target? What are the specific needs of our patient population? What's our business case for pursuing care management and investing in population health tools and strategies? And then based on that, who are the right care team members who we need to support these patients? What are their credentials, and also where are they sitting physically, either within practices or maybe even in a contact center? The next piece is more operationally. Oh, go ahead.
Oh, yeah, I was just going to add to this point, I think sometimes it's hard to think of how the patient services or increasing the customer care from a communications point of view it gets a little bit fuzzy, because people may already have a contact center, or they don't consider themselves a contact center, and they've been doing one set of functions within maybe the marketing department, but and not thinking about how that department could expand, or even expand its responsibilities, or even expand past that room where those folks are in, and know that it can expand to other parts, even in satellite offices, or maybe a couple of nurses in another facility, can actually integrate into this new way of communication and be able to benefit the business in more aspects than what's being used today. And with even departments, like I said, that probably don't consider themselves a contact center, but the technology needed to facilitate this type of proactive communication can be used. So just want to add to that. You may want to think outside of what you typically are already using that for, and think this can expand. As we talk to a lot of healthcare providers and say, the marketing department say, well, now we have all these other responsibilities that IT is throwing on us because we have this technology and we don't know how to do it. We're going to go into other means in which you can better equip your contact center agents who may not be immediately prepared to handle other types of inquiries.
Absolutely. And as we get to the center of the graphic and we're thinking about some of the functions that are creating some time pressure for practitioners who are in actual primary care offices, patient enrollment is really one of those key tasks. So, we've identified some high-risk patients or patients who might be behind on their preventive screenings. How do we actually engage them and outreach to them so that they're actually utilizing and maximizing on the services that we have to offer? Then once they're enrolled, particularly in a care management type of program, what are the different workflows that we're establishing to manage those patients? What are the care plan goals that we're setting up to help them achieve their own personal successes and also help us succeed under value-based contracts? Care coordination is obviously huge here too. We just talked about the silos, but how are you coordinating across providers, strengthening your relationships, and thinking beyond just the site of care that you may work at, but also thinking about the broader network. So particularly important for ACOs here. And then, of course, the final consideration, important for everything in population health and healthcare in general, is just measuring and evaluating the performance of everything that you're doing. So we'll spend a little bit of time talking about metrics and outcomes that providers are really looking for, that contact centers can also help support the achievement of. So just to deep dive a little bit on consideration number 1, which is around those care management goals and the prioritization of effort. You're probably pretty familiar at this point with the patient segmentation pyramid, but I do think it's really important for thinking through how organizations are blocking and tackling. So the main takeaway here is that providers aren't just managing one patient population, but 3, and each of these populations has very distinct needs, and you're going to apply a different approach to each one. But if we sort of simplify this, at least initially, the priority for most organizations is on the top 5% of patients in terms of cost. So they're the ones with, 4 or 5 chronic conditions, psychosocial barriers, acute illness. This is really where we're targeting our high-risk care management support. You don't want to forget about the middle layer of patients, however, just because this is the greatest chunk of patients you're going to have in any practice or health system. These are the individuals who have a couple of chronic conditions or maybe at risk of developing some chronic conditions, and where you want to target them here is in providing additional education and support to really prevent them from becoming high cost and high risk. So these folks just need a little bit of extra coaching and support to help them keep their conditions under control. So telephonic check-ins are often extremely helpful here. And finally, you have your healthy patients, so your 35% or so with no active disease diagnosis. And your primary goal here is to keep those patients loyal, connected to your health system, and committed to wellness. So the best way to do this is just to make things easy for them, just like we do in other industries. So easy to get appointments, easy to get in touch with the office if you have questions or concerns, reminding them when they need preventive services or when they have an appointment coming up. Functions like that that really make your life easier. And I think the best thing about this is it does give you some guidelines for how to guide the amount of effort that you're applying, but the model is completely flexible. So, you know, we've seen top 1%, top 3% being the high-risk category and sort of shuffling from there. But the important part is just that you have a strategy or approach for how you're tackling these different populations with different needs.
Yeah, and what you could do is for the contact center side of things and the patient care through the telephonic solutions is perhaps you'd want to have some voice or telephone call follow-up for the rising risk. You maybe want to give them a little bit more personalized advice on what they should be doing next, and are they following those specific care details, all of which could be prompted through a connection to your EHR EMR platform so that you make sure that you get it right every time, no matter who the agent is who's following up with them, either in a queued outbound call or if you're doing it just through working through some specific lists. And then on the bottom part, it could be automated interactive SMS messages or maybe emails that would have a quick link to your patient portal that has all the forms that they could fill out ahead of time. All of those solutions can free up and make your resources more efficient so you can spend more time with the face-to-face interactions where that top 5% of high-risk patients actually need it. And you can, like I said, move your resources better across balance them better for who needs the most care when.
Mm-hmm. And that's an excellent point. So every organization is going to have different goals that they're focused on achieving. But what you can see here is just some common focus areas for potential savings. So we're often looking at utilization targets, so shifting care from high-cost settings like the emergency department or the hospital more into primary care or other outpatient sites. So we're tracking the number of visits of each type. Sometimes prescription drugs come into play here, so how are we encouraging generic prescription drug utilization or driving down total cost? Other times we're looking at specific disease states. So again, another really salient point when we're thinking about contact centers and folks who can be providing targeted support to individuals with a specific condition. And then finally, you have to be thinking about different quality indicators and what payers are incenting here. So there's readmissions penalties, there's a lot of quality measure sets that we need to be tracking. So how are we mapping these savings opportunities to the way that we are deploying our resources and investing in different technologies?
Creating that business case for, hey, we need this type of stuff, but how do we prove it? Because it can be costly depending on how sophisticated you want to get. Connecting the dots between the ways you can save money or gain money through the more efficient service is a good way to start that discussion.
Mm-hmm. So second consideration here after you sort of put together that business case is who's going to be on your care team. So here's where you want to think a little bit more broadly beyond who's just within your primary care practice or who's sitting within the hospital setting. You have a lot of really important players who have important roles to play in helping to achieve some of those goals that we just mentioned. So I won't spend a ton of time here, but do just want to orient you to some of the key roles that we get a lot of questions about and that folks are really trying to integrate into their daily operations. So the first is no surprise, it's that high-risk clinical support role. So this is the person who's tasked with managing patients who are at the top of the risk pyramid. You know, they've got a lot of chronic conditions, they need help coordinating between all their different providers, they need that self-management support. They might need support with some non-clinical risk factors that are impeding their ability to adhere to their care plan. So typically a very experienced nurse or social worker who fills this role. We often see them embedded directly within the primary care practice, so working side by side with a PCP, for instance. But there are many models that exist that we'll get into in a little bit. The second type of role that we see is that moderate risk support role, so the one that falls in the middle of the risk pyramid. So here again, they're really working with those rising risk patients to prevent them from needing that complex or high risk care management. And because it's more educationally oriented, it can be filled by a variety of people. So we've seen upskilled medical assistants or LPNs, for instance. So it doesn't necessarily have to be an RN or a physician in this role, which can really help with expanding your options, which is why we often see this type of resource centralized in some type of contact center to really give you a lot more scale and the ability to work with many more patients than you otherwise would. The other two roles that I have outlined here are a little bit more specialized. We have seen providers beginning to integrate them directly into primary care practices. So behavioral health, pharmacy, and non-clinical staff members are often the most common ones. So really thinking about what are the non-clinical needs of patients that are impacting their ability to adhere to their care plan, and how can we better support them there. So we talked about selecting your target populations, how to think about members of your care team. The consideration number 3 is really around how to deploy those care team members in terms of their physical location. And in terms of what we've seen from other hospitals and health systems, there's really 4 common models here. So the one I just alluded to, where you're embedding the care managers within primary care practices to really provide some additional support outside of the context of a traditional visit. The second model, which I'd say is also incredibly popular, is centralizing within some type of administrative office or offices. So everybody's working in a single location, and the work with patients is more telephonic than it is face-to-face, although we have seen some models where the telephonic approach works for 95% of the interactions, but 5% of the time they're actually going to go to the patient where they are, whether it's at home or in the hospital, to actually supplement some of that care. Another type of model, less common I would say, is dedicating care to a complex care clinic. So you're actually building a new type of facility for your high-risk patients. You can provide all the specialty services under the same roof. And the final model is having those care managers operate in a mobile or sort of community-based orientation. So they're going wherever the patient is along the care continuum and meeting them face-to-face. So obviously all these things have different pros and cons. There's not a single one that's right for every organization. I'd say one of the benefits of embedding within a primary care practice is that you do get to build those face-to-face relationships. But a major con that we hear about is that these providers who are tasked with a very specific and very special responsibility often get pulled into other responsibilities that maybe should not be under their purview just because they're physically there and can be asked to do them. So it really helps to preserve their time and maximize on their clinical licensure to keep them centralized in some type of administrative office where you can really streamline and standardize your efforts.
Yep. And if you can't bring everyone together, or if that's not an objective, you can still have, like for large health networks where you have multiple clinics and hospitals and urgent care facilities, they can still be on the same contact center type instance where they're all able to utilize the functionality and communicate with patients together, even if there's different maybe EMR platforms that they're using. You can still utilize it as a whole as opposed to maybe breaking it up between the organizations or having it be disjointed. The hybrid model means it doesn't matter where the equipment is or where, if your EMR is on which site, you can make sure that you can still utilize that and still act as one cohesive unit where you're communicating efficiently to all your patients.
Mm-hmm. Excellent point. So just wanted to share a specific case study from an organization that does use a centralized model for their care managers. I think it's interesting, and I like to show it because they actually started by embedding their care managers within practices But as I mentioned, they found that their nurses were really getting pulled into a lot of care management duties, so they were spending only about a quarter of their time on the things that they were intended to be spending it on. So they decided at that point to centralize all their care management resources. So now these care managers who are working with high-risk patients with multiple chronic conditions are doing almost all of their patient visits or interactions by phone. They, like I said, can still do some of those home or hospital visits as needed, but most of their work is remote. They also have an RN care manager on call through a dedicated phone line that enables patients to schedule appointments and request advice, which really helps keep costs down and provide some additional patient support to supplement some of that coaching that they're receiving from the other RNs. And just if it's of interest to get a sense of scale, between the two programs, they have 15 full-time staff members who are covering 49 physician practices, and they're able to cover many more patients than most embedded programs. So again, gets you a little bit more bang for your buck and some more scale in terms of the number of patients on that risk pyramid who you're able to address. And as you can see on the right, a lot of really positive outcomes coming from this type of targeted approach where you're really working to engage patients through this type of telephonic interaction. So they've seen a reduction in total cost of care for these patients, a reduction in readmissions, and also a reduction in avoidable ED visits as a result of this approach. And centralizing care managers or care management duties can be a huge win, but it's not always right for everyone. So I just want to leave some of these questions for your review. There are things that we encourage health systems to consider when they're deciding the right deployment approach for them. So things like how dispersed is a patient population, is geography and reach a problem when you're thinking about having people come into an office versus being able to contact them and provide a lot of extra support over the phone. Do you even have the physical space to co-locate staff? So you might not be able to embed them in a practice if you don't have a place for them to sit, for instance. Information sharing is another hurdle that we often hear about. So how well are you able to share information across settings? So those factors take us through what providers are thinking about when they're deciding which patients to target, who to hire to support those patients, and where they should physically sit. So the next considerations focus more on operations and actually getting patients enrolled in a care management program and managing their care plan. So starting with the patient enrollment piece, the three things that we have to do when we're enrolling patients are first just identifying them. So we see this oftentimes happening very reactively in response to utilization. So you really want to think about the tactics you have at your fingertips to really be more proactive in your approach to build a sustainable program. So here we're thinking about, triggers that you can build into your IT system to alert someone that they need to outreach to a patient. And you can even customize your approach from there depending on what that trigger might be set up to do. Second,
and that trigger could also, I was just going to add, if you have a trigger set up in your EMR HR system, that could also be synced to the contact center so that you don't even have to have a middle person saying, okay, here's all the people who we need to proactively outreach to, and then let's get that over to the contact center, and there's a delay, and someone's got to standardize it, and then load it into a queue, and then say, okay, who do we sign these out to? That can all be automated, where the second one of those triggers gets hit, it's built into the contact center's queue and can automatically be assigned out. So then you do a little bit more work up front, and then ongoing, it's just an automatic thing where you're getting people right at that moment where it's top of mind, and they're going to be more incentivized to join the program.
So that ties in nicely to the second consideration around how to actually outreach to patients. So just making sure that you have some really clear standards in place to make sure that the efforts that you're putting forth are actually returning positive outcomes in terms of both clinical and financial reach. And then lastly, messaging is huge when we're talking about anything, but particularly here when we're talking about some of these newer services that patients may be less accustomed to or less comfortable with utilizing. So we really want to make sure that we're taking to heart the fact that different patient populations have different concerns. So we want to be able to appeal to them in different ways that are really going to assuage their fears or make them excited about participating in some of these features or programs.
Yep. And this is actually fairly common in the commercial space and already used in major contact centers already, where every type of call that gets made or incoming call that gets made based on what type of a customer they are, maybe you're talking to them about, so for instance, if you're a cable company, you have someone who's calling in about IT or their internet or their cable, and then the agent should automatically know that. It could be the same thing here, where based on what type of patient they are, it can provide a script or a screen pop for the agent to already have that quick list of questions and FAQs that may be pertinent to that conversation. That way the agent doesn't have to go search for it at the time, or that nurse doesn't have to go search for it at the time. It just automatically populates for them so that they can be more readily prepared for that conversation when it happens.
Mm-hmm. And I think that's really key, because I've spoken to a number of organizations who run into the issue of patient resistance or less than ideal enrollment figures, or sometimes it's challenging for the folks who are tasked with doing the outreach to manage all these different personas and needs and things. So what we really encourage here is customizing that scripting based on a patient's needs. So the example here I've included just briefly is from Henry Ford Health System in Michigan. So they refined and personalized their scripting to do a number of things that we consider best practice. So the first is introducing a care manager by name and including a professional biography or credentials. So as you can imagine, it really helps to be able to attach a real person to what's being explained. It's not just some sort of ambiguous program being sponsored by a payer or from a hospital or someone that you've never heard of. It's really customized to your care team, your trusted physician or care provider. The good types of outreach also explain the purpose and goals of the program and really emphasize that it'll be provided free of charge. You also want to think about how to frame this in the context of what would be appealing to a patient. So I know often health systems get really caught up in, improving their quality scores or addressing their readmission rates, but, the patient is going to care about being able to better manage their medications or feel better or meet their personal goals. So we sort of acknowledge that in best class scripting. You also want to list any patient incentives that they'll get from this type of program. So we often see free transportation being included here for the in-person types of supports, or maybe other things that you would substitute there, but what else would the patient get out of it that they might not be expecting? And then to the extent possible, sort of emphasizing the connection to the trusted care team. So, referencing Dr. Smith or whoever they typically work with, so that they're more inclined to engage in the services that you're offering. So some common things where we see customization are for self-insured employee populations. So, these are healthcare workers, so they have concerns around privacy and such. So you're going to angle or position your scripting there a little bit differently than you would for a Medicaid consumer or a Medicare consumer, for instance. So I think having these different types of stakeholder groups really helps you customize your scripting, but also gives you a way to scale all these efforts across a wide population, given the number of responsibilities that folks are tasked with addressing. So consideration 5 really pertains to what we actually do with patients. So all care management efforts ultimately are building towards this goal of helping patients to self-manage their condition and really be more empowered to take on ownership of their own health. So I won't spend a lot of time on this slide, but the thing I do want to highlight is throughout all those phases where a patient is working with an extended care team, there's certain things that we might want to automate to maximize efficiency and enable the care team to have more face-to-face time with patients. So some examples of things providers are looking for tools to automate are those enrollment triggers for patients who are appearing on disease registries or being identified as higher rising risk, as we talked about. Also alerts for patients who might be overdue for a screening, who may have missed appointments, maybe patients who have been admitted to the hospital, so they've previously been working with someone telephonically. We want to know if they've actually escalated and shown up in the emergency department or the hospital, and the right people need to know. So transformation points really vary organization to organization, but I think with the right tools you can save a lot of time and a lot of money and really maximize on building the relationship with a given patient. Consideration number 6 is care coordination. Again, won't spend a ton of time here, but suffice it to say this is really an evergreen challenge for every hospital and health system. We're asking a lot of new things of providers, not only in terms of tasks, but also who they work with and how. So particularly when we're thinking about ACOs, you know, it's not just about the folks in your primary care practice. You need to be working better with specialists. You need to be working better with post-acute care partners. And we're even pushing farther and farther out into the community to think about, you know, how does the hospital work better with a food bank or with local housing authorities or the Center for Aging. So you want to have a robust way of understanding who all these different players are, what they're offering, what their responsibilities are to a given patient, and also how they're sharing information back and forth so that you can paint a more comprehensive picture of a patient's care plan and their needs and where their touch points are across the continuum.
Yeah, and some stories that I've heard is where someone will be admitted to an outpatient facility or a specialty facility after they've left the hospital or primary care facility, and they beat by even hours or days the information about them, and mistakes are made right out the gate just because there's lack of communication or lack of information being transferred in time. So that's where a contact center can step in if you have any type of facility already built or function where this type of communication occur, where a contact center platform can say, all right, I see based on the information in the EHR that this person was just discharged and the referral is this doctor at this facility, and automatically can trigger an information email that goes out to that next facility into their queue, into their record keeper, and they can start to work on that immediately before that person has even left the first facility. So that type of communication is certainly within the realm of capabilities for the technology that's available today. It just has to be built out, and finally we've gotten to a point where revenue is being actualized based on that type of improved care, and so there's more of a business case and more of a benefit for the actual organization to move forward with some of these initiatives.
Mm-hmm. Great. And last but not least, metrics. So people are spending a lot of time tracking a lot of metrics, and they're really looking for 2 improvements here. So 1, how to streamline collection and analysis efforts, and 2, how to ensure that the things that are being measured are really the ones that can show ROI. So this is another page I might print out and have handy, since it provides a good overview of the categories of metrics that are particularly important when we're thinking about care management. So they span all the areas that you see here, so patient identification, comprehensive care and access, big focus on preventive care and utilization, and then also those care coordination and patient engagement elements that we've been talking about throughout the presentation. So you may notice that many of the metrics are outcomes related, so readmission rates or per member per month cost of care, but others are related to specific processes to gauge how well interventions are working at a more granular level. So I think the more and more you can tie a specific service or intervention to concrete outcomes, and particularly if you can estimate dollar savings, the more you're continuing to build that robust business case. So now I'm sure we've gotten to the part that many of you have been waiting for, which is really how to pitch or use contact centers specifically to support these care management and population health goals. And I do hope that that first section was interesting, because frankly, this is where providers are asking a lot of the questions. These are the terms that they're familiar with and what they're looking for and where they're looking for help. So just understanding how contact centers fit into broader population health goals can really position you well to help connect the dots, solve their problems and really know what questions, frankly, that they aren't even asking and how you can help them there. So this slide is an excellent summary and another one that I'd bookmark. So getting into call center functionality here, what we've done is break down sort of more traditional contact center functions that we've seen in the past and compared them to more population health related functions. So as we're talking about getting more proactive instead of always being reactive and thinking about health and wellness in different ways, what are some of the ways that we're seeing hospitals and health systems expand their contact center functionality to really hit on some of these key population health goals they're being asked to achieve? So across the top, you can see exactly what those functions are that we typically see profiled. And then down the left-hand side, we show some of the key benefits that we see related to each of these functions. And the ones that we've boxed in red here are the ones that are particularly important objectives when you're thinking about a value-based environment. So how are we doing with disease management? Diabetes, hypertension, COPD are really huge here. Medication adherence. So, often the management of chronic conditions involves taking a lot of medications. 50% of Americans are on at least 2 or more prescription drugs at any given time. There's a subset of patients who are on 10 or more, so how are we making sure that they're refilling those prescriptions, that they're taking them, and they're actually using them for wellness? Care coordination, as always, how are we breaking down silos across the different care sites that Scott mentioned? Also thinking about reducing ED utilization, so directing patients to the right site of care so that they're not overshooting and utilizing some of these expensive services when maybe primary care or urgent care or even a nurse triage line could support. And then also just avoiding readmission. So how are we doing our duty to make sure that patients who are discharged from the hospital have all the support and education that they need to really manage their condition or sort of recuperate once they're back at home or in a post-acute care facility. So as you can see, the traditional functions really focused on attracting new patients and driving system loyalty. We continue with those objectives moving forward, but we really are adding those ones that I just outlined to think about those specialized services we can be providing patients at each of those 3 levels of the risk pyramid.
And I think another big difference, if you were to add another variable to this, is that the items on the right side are probably more closely associated with lowering costs and increasing revenue than the ones on the left side that maybe were just a matter of the need to facilitate some kind of necessary communication, not necessarily tied directly to improving patient care and keeping costs down for the patient through the hospital.
Mm-hmm.
So it's also more exciting to see this chart as these new possibilities come about.
Absolutely. So just to do a little bit of a deep dive on some of these functions, I want to start out with bundled reminders. So here we're talking about contact centers identifying overdue or upcoming preventive services and scheduling appointments in real time for patients and dependents during a single call or a single interaction. So key population health benefits here, obviously disease management and also care coordination. So you're increasing the utilization of preventive services, you're closing gaps in care, you're providing coordination and visibility across a range of providers and settings when you really aggregate all of these needs. And obviously this creates a much more unified and enjoyable experience for patients. They don't have to be receiving a number of phone calls or worse yet, having to remember all the things that they need to call in about. Someone is proactively reaching out and sort of grouping all these things together for them so that they have all of their care needs under control. And I particularly like this type of support because it helps support healthy or low-risk patients. I know many of the functions we'll talk about are typically focused on high-risk patients, but this is something that's really helpful and valuable across that risk pyramid.
And one thing on this that is very familiar to the non-healthcare space, if many of the people on the call came from a non-healthcare contact center environment, was brought into a healthcare one, this is very similar or identical even to the customer journey mapping that a lot of commercial companies are using to be able to provide that end-to-end experience where there's less communications but much more efficient communications across their providers. So when we were reviewing this slide before, I mean, being able to say, okay, yes, that's great, you have this prescription, it's going to be at the desk, but then also I see that you have 2 kids that are due for checkups in a month. Do these times still work? Do we need to make any special arrangements for any specifics that pertain to that child's care? And you can address all those changes and create that better, more comprehensive customer journey. And as there's so many more healthcare options out there available, if you feel that warmed, welcomed, and taken care of from a service perspective, that's going to translate into a better in-office experience and increase the loyalty to say, I really enjoy the experience I have from my healthcare network.
And from the tactical side, just being able to prioritize your patients and for whom you're outreaching by either number of gaps in care or some other metric for outreach is really key to maximizing this function. And the example that we drew in the literature here is from Carolinas Healthcare. They used a process just like this, and they report that about 40% of their calls actually result in successful scheduling of services. So these are individuals who otherwise would not have been engaging with the healthcare system. It's a direct impact that this type of bundled outreach and reminders have on patient care. Another big patient satisfier is centralized prescription refill lines. So I'm sure most of you are familiar with the process of trying to refill your prescriptions in a convenient way, sometimes succeeding, sometimes perhaps not. But the example here we show is a before and after from Sharp Steely, where patients originally had to call into primary care to request their prescription refill. Somebody would record that request. It would get transcribed. The message would get sent to their primary care physician, who would then have to find time to approve the prescription refill, circle back with the patient, and then they could pick it up. So obviously not a patient-friendly or time-efficient process. So what they did is pull all of those prescription refill processes into their contact center. So now a patient has a single phone number that they call for their prescription refills. It gets routed to the designated clinicians, and the clinician can send to the appropriate physician and get approval. Sometimes it's an automated process. It doesn't even require the person if it's sort of a standard refill. But a lot of pathways there to make this easier for patients. And in terms of their particular outcomes, they're processing about 300 requests per day, which would otherwise, with the old model, have been addressed directly by physicians, so saving a ton of time and giving them a lot more time in their day to focus on those face-to-face interactions that matter. The next function is fairly simple but extremely high impact if you have the right IT. So here the concept is that reminders or other content like wellness tips can get set up through an automated system that sends through the patient's preferred form of communication to really save time and increase patient satisfaction. So we're thinking about scheduling reminders, either for preventive services or for specialist appointments. There's also appointment reminders so that we can minimize that no-show rate. And then you also want to think about those health-based calls to action. So every hospital and health system is going to be investing dollars in certain types of initiatives. So maybe they have some kind of diabetes management program that they're really trying to push. How do you make sure that patients are aware of those programs, they understand how to benefit? If there's follow-up from any of those types of programs, like just reminders or prompts or lifestyle encouragement tips, those types of things, those can all be set up to be automated, all according to the patient's preference. So not everybody's going to want to receive a phone call, so really they're maximizing on a bunch of different channels, so email, text, patient portal, whatever it might be, and the patient is selecting their preferred form of communication here.
Yeah, and that's something that most contact centers, again, of any industry, are looking at, is trying to make sure people are contacted through their preferred channel. And Rebecca, to stress your point of the patient portal, a lot of folks are either responsible for, or the network in general has put a lot of money and resources into a patient portal or maybe even a patient app. Well, these types of, basically almost everything that we've covered today, but especially appointment reminders, that can be built into the portal or the application itself through the contact center to drive more proactive traffic into that place where it's built out to be a much more robust informational center than just these transactional pieces. But if you drive these transactional types of communications through or back to that portal, they'll get more familiar with it, and then all those investments that you're making to try and improve your population health through the portal can hopefully be better actualized because you've connected the two together through the contact center, which, like I said, many e-commerce type or even retail places is already being done today. So why not take advantage of the way people are already interacting in other places in their life outside of the contact center, or I mean outside of healthcare, but into the healthcare, and maybe even make it more efficient because your healthcare is way more important than buying a pair of shoes. Well, maybe not to my wife, but to most people.
So this is another great example. You can use it across all those patient risk levels. One other example I want to provide for high-risk patients that contact centers can really play a pivotal role in providing is follow-up and care transition support. So folks who have showed up in the hospital or the emergency department, probably pretty vulnerable and need some extra support, so we want to check in on them. So the concept of follow-up, of course, is not novel, so, but how can we become more proactive and more holistic in the types of support? So here we might be calling in to check in with patients after they leave the ED or the hospital and support them to improve their medication adherence, ask if they're having any side effects, if they were able to pick up their prescriptions at all, if they have any questions about their care plan, want some piece of education reinforced, whatever it might be. Maybe it's getting some follow-up appointments scheduled or getting in touch with a nurse. This provides a one-stop shop experience for them to get all that extra support and really feel more connected to their health system and feel like, you know, they weren't forgotten just because they left the healthcare system. So example here comes specifically from an ACO where they really had a lot of patients who had been showing up to the ED. So the process here was to check in with them 48 hours to see if there was any health-related issues, check in on the medication adherence, et cetera. And then of all, the last function that I'll mention here is virtual visits. So this really expands on the nurse triage function, which we saw in some of the traditional functions. But what it does is enable patients with common conditions the opportunity to receive a diagnosis and treatment plan online. So the simplified workflow here is the patient completes an online triage form via the website. So they indicate what their symptoms are, what's going on. A nurse practitioner in the contact center validates their treatment plan. They fill in any necessary prescriptions, and they respond to the patient via text or email when the care plan is complete. So patients love it. You know, it saves them a ton of time. It might take 2.5 hours for you to go to an in-person office visit, take time off of work, but this type of interaction might only take you about 30 minutes. And as you can imagine, this is also a big physician satisfier. So providers can then free up some capacity to see new patients face-to-face while they're keeping their old patients loyal to the system, connected, getting the services that they need. So it makes a lot of sense for these common conditions you see outlined on the bottom of the page here. And for this example here, which comes from Health Partners, they use the platform Virtuel. In addition to that time savings that I mentioned, they have quantified their savings here as being at least $88 per case by transitioning this type of service from face-to-face to virtual. Great. So with that, I know we only have a couple of minutes left. I really hope that this was helpful. I've included in the takeaways the framing graphic here that helps recap some of the considerations that providers are thinking about when they're trying to figure out how to optimize their care management infrastructure. I've also included a recap of some of these traditional versus population health functions that we see in contact centers. And with that, would love to open up the floor to any questions that you might have.
All right, we have a question that regards to video and how it can be used as well. So we've seen video being used in a few different ways. We've actually seen video being used where it's plugged into a kiosk for in maybe an urgent care. You can use a contact center software where you can connect to a kiosk with an agent, and then instead of waiting in line or waiting in the waiting room, for something, one of those, that slide that shows some very low risk type ailments, you can get addressed very quickly. They can look up your after they diagnose you, look up your pharmacy, send your prescription over, all automated through the platform in connection to the EHR system. Another way you can use video is if you have possibly a UC platform that you're implementing, such as Skype for Business or something like that, where you have a contact center solution utilizing that infrastructure, and you can pull in other experts from within the hospital network who can be made available to help assist on a call if something needs to be escalated quite quickly. If you need to have a video conference to actually see something with someone at home who's accessing through your website or portal, you can do that. There's all sorts of new ways, more bleeding edge type, cutting edge type technology in situations where someone's really trying to push the boundaries of what's possible, but it is being used more and more. Though it's not common, I think more so people are starting with better SMS reminders, better use of email, better proactive use of care through proactive outbound calling.
Mm-hmm. We had another question just come in around what roles we're looking at for the providers who are making these types of decisions. So we mentioned the Chief Transformation Officer role. Titles vary organization to organization, so you're not always looking for the same person. But Vice President of Population Health is also very critical in these types of decisions. Sometimes it's the Director of Care Management or Case Management. Other times they might have a dedicated role for a contact center at an institution, so it's really quite variable. But any of the newer titles that you're starting to see beyond your typical C-suite, where they're related to risk-based contracting or population health, are really your targets here.
Yeah, getting more of the organizations involved that will benefit from some of these solutions will, one, get more resources behind it to make it effective and help fund it. All right. Looks like that's all the time we have for today. We've run up against the hour. So again, I'd like to thank the advisory board group to providing this information and giving such great context for how to improve the concerns that we're all facing today and how it can be connected to the customer care contact center. So thank you, everyone. If you have any extra questions, go ahead and feel free to reach out, and we will respond as fast as possible. And the slide and recording will be sent out in the next few days as well. Have a great day, everyone. Thank you.
Thank you. Bye.